going to do is just talk a little bit about fortification of human milk at lower feeding volumes and look at some of the information with regard to the association of early fortification with growth. And then I'm going to spend just a few minutes on the relationship of changes in z-scores and growth velocity. I have no conflicts of interest to disclose. Studies of fortification of human milk feedings at lower feeding volumes than 80 to 100 mLs per kilo per day, which has previously been a standard, have found mixed results with regard to improving growth. There have been two systematic reviews recently, one by Alia in 2020, which included just randomized controlled studies, and they found just two studies, the one by Shaw and one by Taheri et al., that both included infants supported with bovine fortifiers that concluded no benefit from early fortification, but also no adverse effects. There was a second one by Tinganathan, which was a Cochrane review, which also included only randomized controlled studies. And again, just two studies, the study by Shaw, and then the study by Sullivan, which was conducted in infants receiving an exclusive human milk diet with a human milk-based fortifier. And again, they concluded that there was no benefit, but no adverse effect. So what I've done is I've gone through those two studies, and then also looked again on PubMed and some other resources to look for further studies, but including what I'm including in this brief analysis is also not only randomized controlled studies, but also retrospective studies, because Cochrane Review actually says it's also legitimate to use randomized controlled studies as well as retrospective studies. For human milk-based fortifier studies, actually the only studies I was able to find was the Sullivan study, which was published in 2010, and then two studies actually that we have done. One was in 2018, or published in 2018, which was a retrospective study. And that study also included data from an earlier study that was published in 2014, that was published when we were fortifying at 80 to 100 mLs per kilo per day. The difference in the two studies is that the earlier study included infants less than or equal to 1,500 grams, whereas the 2018 study included infants less than or equal to 1,250 grams. So actually about 3/4 of the infants in the 2014 study with the higher, the greater birth weight spread were actually included in the 2018 study. One other difference was that in 2014, at that time, the infants that were placed on the human milk-based fortifier were infants that met criteria for being at higher risk for necrotizing enterocolitis, or were more acute. And so I've included the crib scores for these two studies just to be sure that the groups compare with regard to their possible risk for NEC. And as you can see, actually the crib score for the infants that were fortified earlier was actually higher than the infants that were fortified later that were included. And as you can also see, is the gestational age and gestational ages and birth weights are almost identical. So I think that's a valid comparison. And then the other comparison is a study that was done in or published in 2020 that was a retrospective study again, but this included 4 NICUs that were not included in the first study, the 2018 study. So looking at the growth velocities, what you can see is there is a trend for improved weight gain velocity in all 3 comparisons. In the retrospective studies, the multivariate logistic analysis that was done also found a significant association with weight gain velocity associated with earlier fortification. And the same was true with length. You can see in all 3 studies, there is a trend for some improvement in length gain velocity as well. For head circumference, only the 2014-18 comparison shows an improvement in head circumference, however. For clinical outcomes, for late onset sepsis, there also is a trend for a decreased incidence of late onset sepsis in all 3 comparisons, although minimal in the 2020 comparison. For chronic lung disease, there was no improvement seen in the Sullivan study, but in the 2 retrospective study comparison analyses, you can see that there is a trend for some improvement. For ROP, there was an improvement in the Sullivan study and in the 2014-18 data, but not in the 2020 data. And for NEC, there's really no significant difference being shown. Putting the data together, and again, this is just a preliminary analysis, but I think it does show some trends. You can see that these babies were about 27 weeks gestation, 900 to 950 grams birth weight. There's no, and this is just using a screening t-test and also for the continuous data, and then chi-square test for the clinical data. But you can see there's no significant difference using that screening test for weight gain velocity, but there is what appears to be a trend for improved length gain velocity. And there's minimal improvement with regard to head circumference. For the clinical outcomes, again, there's no difference in significant difference in the incidence of necrotizing enterocolitis, but there are the trends for decreased late onset sepsis, chronic lung disease, and ROP. And this is total ROP. For the bovine-based fortifier studies, I included the Shaw study and the Taheri study, which were included in the initial analyses that I showed you, but also found another study of the retrospective study of Tillman to include as well. And these studies, as you can see, are performed in infants that are of a little bit higher birth weight and gestational age compared to the human milk-based fortifier studies. I was really only able to obtain data to compare the weight gain velocity well in the Tillman and Shaw studies. I wasn't able to obtain the standard deviations in the Taheri study, but you can see that there's really no difference significantly in the weight gain velocity. For length gain and head circumference gain, there was no data in the Tillman study, but in the other 2 studies, the comparisons were using the change in z-scores. And again, there was no significant difference. For clinical outcomes, there was just data for late onset sepsis and NEC that was consistent through all 3 studies. Again, there is a trend for a decreased late onset sepsis shown in the Tillman study, and a decrease also in the Shaw study, but not in the Taheri study. And again, there's not really a significant difference shown in the with regard to necrotizing enterocolitis. putting the data together, you can see there's a much lower number of babies in this comparison, and that the infants are of higher birth weight and gestational age compared to the human milk-based fortifier studies. But there is a trend for decreased late onset sepsis and no difference in necrotizing enterocolitis. So in conclusion, with regard to early fortification, this limited analysis suggests that fortification of human milk feedings when enteral feeding volumes are less than or equal to 60 mLs per kilo per day does appear to be safe. Earlier fortification appears to be associated with less late onset sepsis, although other practice changes focused upon prevention of line infections during the time frame of these studies may have influenced this association. Data from studies of infants supported with human milk fortified with a human milk-based fortifier suggests that starting fortification at lower feeding volumes may improve at least growth in length. But more study is needed with regard to the optimal fortification strategy as it relates to growth, body composition, and long-term outcomes. The impact of targeted fortification in bovine casein hydrolysate fortifiers upon the outcomes need to be evaluated. Studies of newer bovine fortifiers have predominantly been performed in more mature infants and in infants of greater birth weight than human milk-based fortifier studies. So with that, I'm just going to go to a discussion of weight gain, velocity, and changes in Z-scores, because as I'm sure you might be aware, the trend now is to increasingly report changes in Z-scores with regard to outcome measures for nutritional studies of neonatal infants. Although weight gain velocity is also still commonly published as well. This graph is just showing the weight gain velocity throughout gestation. And as I'm sure you're aware, there is a gradual decrease in the weight gain velocity with gestation or with postmenstrual age. This is data using the 3 growth curve publications, the Babson growth curve, which was used commonly in the late 70s, 80s, and 90s, that was done including infants born at sea level. There was another growth curve that was frequently used during that time, which was the Lubchenco growth curve, but that was performed in infants born at altitude in Denver and doesn't really compare well to infants born at sea level. So I think the Babson curve is more appropriate to compare with the Fenton-Olson growth curves, which include predominantly infants born at sea level as well, or at least at lower elevations. And then I've included the infants in Eckhart Ziegler's study of the reference fetus as well. And as you can see, there's this gradual fall off in weight gain velocity that becomes much more acute at about 36 weeks and continues to fall off. So keeping that data in mind, what I've done here is to compute the weight gain velocity using the exponential formula for infants born at different gestational ages and then discharged at different gestational ages. And in the first group of rows, the first row is for infants, and this data is for boys, although the data for girls is really quite similar to that of the boys. So the first row is computing the weight gain velocity for an infant born at 27 weeks and then discharged at 38 weeks. And in the first row, the infant's birth weight is at the 50th percentile at birth and also back to the 50th percentile at discharge. So the weight gain velocity that would be associated with that based upon data from the Fenton growth curve is 15.6 grams per kilo per day. However, the recent study by Rochelle and et al. Has demonstrated that there is this what appears to be relatively normal fluid loss in the first 1 to 2 weeks of life that results in a change in Z-score between the weight at birth and the weight at the nadir of weight loss in the first 1 to 2 weeks that results in a change in Z-score of minus 0.8. So if we consider that that may be an acceptable normal for an infant born at 27 weeks and then discharged at 38 weeks, where the birth weight was at the 50th percentile at birth with a Z-score that would be 0, and then at discharge was at a Z-score of minus 0.8, which could be consistent with just fluid loss, the weight gain velocity would be 14.1 grams per kilo per day. If the baby is discharged at a Z-score of -1, the weight gain velocity would be 13.7 grams per kilo per day. And if the Z-score is just back at -2, the weight gain velocity would be 11.5 grams per kilo per day. The studies that I have seen have mostly, when looking at change in Z-score and neurodevelopmental outcome, have found that a change that is more negative than -2 is associated with poorer neurodevelopmental outcome. And there's mixed results at a change of Z-score with a change of -1 to -2. So again, keeping in mind the issue with regard to that fall off in weight gain velocity towards the end of gestation, what I've done is computed some other data, and this is for infants, again, born at 27 weeks, but then discharged at 40 weeks after that fall off is beginning to occur normally. And so you can see that for the baby that begins at the 50th percentile and is back to the 50th percentile between 27 weeks and 40 weeks, the weight gain velocity that is associated with that outcome is 13.2 grams per kilo per day. And for a change in Z-score of -0.8, it's 11.9. And as you can see, for -1 and -2, it goes down further. Taking a couple of other scenarios would be infants born at 28 weeks and then discharged at 39 weeks. And you can see the weight gain velocities here. And for infants born between 28 weeks and 37 weeks, again, this is just at the time that fall off is beginning to be more acute. This group has the highest weight gain velocity associated with these different outcomes. Another consideration that we need to do is when comparing groups of infants or infants born at the same gestational age but discharged at different postmenstrual ages. And this example is just for two groups of infants that have the same weight gain velocity of 11.5 grams per kilo per day. But the group in red is born at 26 weeks and then discharged at 38 weeks. And again, at birth, they are at the 50th percentile with a Z-score of 0. But the Z-score for the infant with this growth velocity discharged at 38 weeks would have a Z-score at discharge of -2. So the change in Z-score would be -2. However, the group in green is discharged later at 40 weeks, again, after that fall off and weight gain velocity is occurring normally, so that at discharge at 40 weeks, this infant is at a Z-score of -1. And so this just demonstrates that when comparing groups of infants, you do need to consider the weight gain velocity and changes in Z-score in relation to any differences in postmenstrual age at birth and discharge. This is another example for two groups of babies that have different weight gain velocities. The group in green has a weight gain velocity of 14.2 grams per kilo per day. The group in red, 13 grams per kilo per day. And again, they are born at the same time at 26 weeks with a z-score of 0, being at the 50th percentile. But the group in green is discharged at 37 weeks, and with this weight gain velocity of 14.2 grams per kilo per day at that time would have a change in z-score of -1. Whereas the group in red with the lower weight gain velocity is discharged at 41 weeks. But even with that lower weight gain velocity, it has the same change in z-score of -1. However, if the group in green were discharged at the same gestational age at 41 weeks, the change in z-score would be 0 for that group. And then finally, it's also important to know which growth chart and data is being used for computing the changes in z-scores. This example is for an infant born at 28 weeks with a birth weight of 1,079 grams, which is at the 50th percentile. So a z-score of 0 at birth, and then is discharged at 38 weeks with a weight of 2,736 grams, which is at a z-score of -1. So the change in z-score using the Fenton growth curve is a change of -1 for this infant. However, if you plot the same infant on the international growth chart, you have different results. So plotting the birth weight of 1,079 grams on the inner growth chart at 28 weeks yields a z-score of +1.5 on this growth chart. The sort of turquoise line is the 50th percentile, or a z-score of 0. And the black line is a z-score of +1, and the salmon color is a z-score of +2. Plotting the discharge weight of 2,736 grams on this chart is plots at a z-score of -0.5. So the change in z-score plotted on the inner growth chart for this infant is -2, which compared to the Fenton growth chart, which was -1 for the change in z-score computed using the Fenton growth chart, you can see there's a significant difference depending on which growth chart you're using. So in summary, with regard to growth velocity and z-score, previous studies have found that growth in weight, length, and head circumference in the NICU can affect neurodevelopmental outcome. Weight gain velocity, and changes in weight z-score have all been associated with improved outcome. Because of the fall off in weight gain velocity during gestation, particularly after 36 weeks postmenstrual age, it's important to consider the postmenstrual age at birth and at discharge when evaluating or comparing growth velocities and changes in z-scores. An infant who has the same gestational age at birth, but a later postmenstrual age at discharge than another infant, but the same growth velocity, will have a less negative change in z-score. An infant who has the same gestational age at birth, but an earlier postmenstrual age at discharge, and a greater growth velocity from birth to discharge than another infant, will have a less negative change in z-score if the greater growth velocity is maintained until the infant reaches the postmenstrual age of the infant who had a lower growth velocity and was discharged later. And then again, as I said, it's also important to note which growth curve is being used to compute the changes in z-scores. I do have some the references listed, and thank you for allowing me to present today.
Thank you, Dr. Rapp. Thank you for sharing your presentation with us.